Hi, welcome to the Demonstrating Implementation Excellence stream of SNOMED CT Expo 2023. My name is Farzan Ashrafi and I'm a senior terminologist at the SNOMED CT International. I will be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, if you can please use the Q&A button to type your question to the presenter, and people in the room, if you can use the microphone in the middle of the room. And it's required so the people online can hear you. I am now pleased to introduce Denis Casaubon from American Medical Association, MAA, who will be presenting using a SNOMED CT to CPT crosswalk to extend prior authorization automation. Denis, please proceed.
Thank you very much. Thank you to SNOMED for having me. Thank you for joining me for the next 30 minutes. I am Denis Casaubon from the AMA, Senior Product Manager, and it's my honor today to provide my perspective on the status of prior authorization in the United States today, and the great work that's going into automating it to reduce a lot of the burden that's associated. So you may be asking why why the AMA is speaking at a conference like this. We have been involved in a lot of efforts to further innovation. We are not the tip of the spear creating software services and software for use cases, but our relationship with physicians gives us a great perspective in terms of how to address these different issues in a lot of different ways. For example, we conduct research on pressing issues, pressing challenges. We produce toolkits and different resources for physician practices. We create guidelines around important topics like health equity and AI. We partner with different organizations to further the innovation, adoption, and implementation throughout the ecosystem. And we run some programs that directly work with innovators like the CPT developer program. So today we'll cover some overall process about what's going on with prior authorization, relate that to not just the US version, and then we'll talk about some of the work that's going on to address those challenges, both through HL7 and some of our work directly. So there are two issues that come with prior authorization, focusing in on this component first. The first one is that the process as is today directly hurts patients. When a patient has some kind of ailment, they go to the physician and they expect treatment fairly quickly. The doctor will submit an authorization request if required to the insurance company, and the insurance company often needs to consult with other physicians. They need to gather additional information, and so they'll send requests back to the physician's office. The physician's office needs to conduct more digging into the patient record to get that information. Meanwhile, the patient is paying for this extra time in distress. And then by the time the physician can get that supporting information back to the insurance company and get an approval back, it can be weeks or even months. So this is a very painful process for patients, and the impacts here are pretty stark. So 94% of physicians report that there are some kind of delays associated with prior authorization to the patient care. 50% of those delays or those reports are more than often. So it's really harmful. The impact is that treatment is often abandoned. Up to 80% of physicians report abandoned treatment for patients due to these delays. So if you permit me a little leeway to talk more personally about this, some years ago, my wife and I were going through fertility treatments, trying to have another child, and the pressure, we're not young chickens, And so the pressure to have that treatment go well was already anxiety-ridden. Adding in additional prior authorization requirements, coordinating with scheduling, pharmacies, all of that really adds extra angst to the process. I don't blame prior authorization for our unsuccessful outcome. We do have a wonderful 10-year-old, so in the scheme of things, I feel like this hasn't been a very challenging issue for me. But when I think about other patients who really don't get the care that they need because of administrative delays, it really turns my stomach. The second challenge that occurs is around the burden with submitting these authorizations. So physicians, a recent survey shows that physicians submit an average of 45 authorizations per week. That's a lot. That's paperwork and paperwork and paperwork. And the reason that the process is meant to exist is that payers want to control costs, improve outcomes, and reviews on the aggregate outcomes of that have not shown to accomplish either of those goals. So it's a problem that needs to be addressed. When we think about prior authorization in the scheme of the whole care path, you don't have to read through all of these different things. It's one pain point in a list of pain points. And when we think about the US process, we have a particular flow and relationships that go back and forth. But internationally, there are many of the same pain points. They might have a different flavor. They look a little bit different, but ultimately, these pain points should drive us to find solutions that are scalable and easy to replicate across different models. So we'll look at some of these in three buckets. The first one is around scheduling. When we have an authorization come back, there are often time limits associated with that approval. That can complicate scheduling because if the authorization comes in at a time when the physician's practice is very busy and it can extend really far out, that may be a challenge to get the patient scheduled for the service that they need. The next part is around even referrals when a primary care doctor needs to send the patient to somebody else. There may be a prior authorization required just to get them into a logical next step of care. So it just layers on the challenge and it adds ambiguity to an opaque process that exists already. And then when the physician goes to treat the patient, they also need to complete an eligibility check. So this is where it may differ from other national systems where you don't necessarily have to do all of these authorizations. But in the US, this is definitely a challenge to perform so many different administrative tasks just to care for a patient in ways that are logical and make sense. The second group really focuses on prior authorization. What the talk overall today is. When we talk about the tactical aspects of this, a lot of times the clinical documentation is in SNOMED CT. And then when the provider goes to get the authorization, it needs to be in CPT. That's the language that payers speak. And there are different reasons for the two terminologies, right? CPT is disambiguated and it's related to reimbursement values. And so it makes sense to use CPT on that side, but it also makes sense to use SNOMED CT on the clinical side. So there's a friction there that we need to reconcile. And that's the focus of a lot of the work that we're doing today. Another issue with prior authorization is that physicians need to go into a separate payer portal often. So it's one more step. Not only do they have to submit multiple documents, they need to go to multiple places, multiple logins to do so. And the last piece with prior auth here is that physicians want to do the right thing for their patients. And so if they go to perform a service and they're not sure if it'll be a simple procedure or a complex one, or if there are different entry points possible, they may not know the exact procedure that requires the authorization. And so they can submit multiple services for authorization, but this isn't the case where there's economies of scale with submitting multiple. They need to submit multiple different requests, and so that's just additional burden. And then the third component, once we look at the data that exists, we need to code it somehow. So the first part is that when a physician goes to treat a patient or even diagnose a patient, they may not have all of the relevant data in a codified form. And so it's really difficult to get the full context of the patient's situation. There are a lot of vendors today working on this problem, trying to give roll-up summaries to physicians. So it makes sense. The physician can treat the patient appropriately and spend more quality time with that patient. When they get going on a care path and create a care plan, a lot of those guidelines and established care plans are not in a very data-friendly format. And so there's not as much checks and balances as there should be. So when we think about how do payers really understand, are the proper pieces of care being performed or planned? How do the providers know, what are the next steps that need to happen, and how do we schedule those out? That data is not very easy. I did see an earlier session today where there was a semantic next best or next expected procedure that's worked through SNOMED. So it's great to see that there are people working on these challenges, and so I recommend taking a look at that session as well. And then lastly, once the service is completed, the actions need to be codified. And so it's usually a person who goes in and manually looks through the op note and then converts that into an appropriate code. So all of these issues really focus on how do we meet the needs of the key stakeholders. When we talk about physicians, we want to reduce the burden that they experience performing normal care. Patients want to be seen in an appropriate amount of time and get the correct care. And then payers want to manage their risk and have a business. And so when we think about prior authorization specifically, there are 4 key pain points that we're trying to solve for. The first one is getting the understanding of, does this service need an authorization? The funny part there is that a lot of times we talk to physician practices and they say, oh yeah, we have this one person who knows when an authorization is needed. Authorizations change frequently. People retire, they go on vacation. And so it's very challenging to rely on one person in an office to do something that is programmatic and can be put in a data format. The second question is, if there is an authorization required, what are those requirements? What needs to be submitted with the request? The third is submitting the request efficiently, so it's not an additional burden on the physician office. And then fourth is getting an answer back in a timely manner. So that brings me to some of the great work that's being done. HL7 has a group called the Da Vinci Project that has multiple different components. One of those is a burden reduction work group that has multiple components within that as well. 3 of them directly address prior authorization, CRD, DTR, and PASS. So here, the CRD coverage requirements discovery really focuses on one part where you can get the information about requirements from the payer in an accessible format. just answering the question, is an authorization required? The second one, documentation and templates and rules, is when you have an authorization required, how do we put that into a form in the workflow, pre-filled as much as possible, so it's seamless to submit these authorizations. And then PASS, the prior authorization support, handles the communication with the payer and getting that response back. So recently, the AMA and HL7 signed a collaboration agreement. As part of that, we are taking a more active role in working with this group to address these challenges. We've had parts of the AMA working with HL7 and these work groups for some time, and so now we're kind of improving our commitment to the process. And as part of that, we're looking at how our maps can be fit into the process early on to get from SNOMED to CPT, so that way they're persistent across the workflow. So we'll talk briefly about the CPT to SNOMED CT rules-based cross maps. I know that's a mouthful there. They are in both directions, CPT to SNOMED and SNOMED to CPT. The direction here that we're mostly focused on is SNOMED to CPT. These maps, we're talking about prior authorization today. There are a lot of different use cases that we're exploring for these maps around resource utilization, around improved research to improve outcomes, and again, looking at those care paths to make sure that there's more visibility across. Okay, so when we talk about a specific example of how the maps would be used, we have a SNOMED CT concept that is in the chart, and we map it to several different CPT codes. We classify those maps based on rules that we dictate up front, and it's either fully classified according to the rule, partially classified, or a few other classification levels. Here you can see we have two codes that are partially classified, and one is mapped to an unlisted procedure, a general urinary system code. That can be helpful, but really we're focused on the top two. We want to see what are the best options to send in for an authorization to get a clean response. The question why they are partially mapped and not fully mapped is that the SNOMED CT concept doesn't speak to the specific level of the procedure. So is it simple? Is it complicated? Is it small, large, fragment? And so we do have some semantic mapping to SNOMED CT definitions that can help improve those maps. So for example, if there's the content in the chart that this procedure is being ordered, plus some detail about whether it is a simple procedure or complicated, then the source, the provider, can choose to submit a more specific request or submit a request for both. One of the things that we're working with HL7 and the other partners in the work groups is to figure out how to most effectively use these maps. We've heard that in some cases it's best to send one code if you're fairly sure about what that requirement is. And so there we would look for the most classified version, the highest priority, to get kind of the cleanest, this is a one-to-one relationship, and that's what we're requesting. Another use case that we've heard is around linking the codes requested with RVUs. So CPT codes are linked with relative value units that are equated to reimbursement values. And so some of these provider organizations want to know, if I have 5 different options for procedures, what does my reimbursement look like on the back end? That's not exactly how we promote using these, but it is a good way to understand projections for reimbursement and resource utilization because these components are more than just a dollar amount. And then the last one, like we said at the start, that physicians often send multiple procedures in as a request. So if there are multiple matches for a SNOMED CT concept, it could be mapped to all of those and sent in as a group. So understanding how SNOMED, CPT, the MAPS, the HL7 work groups all fit into kind of the ideal workflow. We can talk through the different steps and see how it is shaping up and should look like. So the first thing is to capture the encounter in SNOMED CT. The two options here are using value sets that are in the EMR directly. That's a typical option, but then we're also seeing a lot of NLP to SNOMED CT. So when there's unstructured text, getting it into SNOMED, because it's such a rich terminology, can really empower the review of that information. There are a couple of sessions, I think, tomorrow around this as well. So I'll be looking at that closely. The second and third piece here, in the CRD process, we would convert the SNOMED CT concept into CPT, and then check to see if there is a requirement for a prior authorization. The interesting thing here is that right now, the implementation guides associated with CRD dictate that payers are required to accept a clinical terminology. So it's a point of contention where it would be great to send a SNOMED concept to the payer and have them do the translation, but it's also not as feasible for them to do so. And so that's one of the key points that we're working with the work groups to figure out is where should we make that translation so it's easier on the process for everyone. When an authorization is identified to be required, the form would be pre-filled in a DTR process as much as possible. The physician can review that form. It's a lot easier than filling it out completely themselves. Send it into the payer, and then if the requirements are all set up as outlined, you should get a response back immediately. There are certainly cases where there's more triage needed for complicated use cases, and so part of the pass process is to get that message back and forth, but also send notifications back to the requester. So if there is a delay, there's an understanding of what's going on, what's the status of that request. Once this is done quickly, then the service can be scheduled much more efficiently. So you might be saying, that's great, it sounds like a good process. Why would anyone want to implement this without motivation? And so the good news is that there are regulation updates in the US that are driving this. We heard from Mickey Tripathi this morning about some of that landscape of regulations. The first one is a CMS rule that we just got word that it is with the OMB currently. So we expect this to drop in the next 60 days. And it applies to both federal and commercial programs. It's going to require FHIR API connections for patient and coverage information. It is also going to implement reporting. We expect it to implement reporting requirements so the payers can be held accountable or tracked to how well they're providing this information in the right formats. There's also a pending ONC rule. We saw the note there that it's expected in November. There was an RFI on prior auth standards in 2022, and we expect it to follow that. and really focuses around certification programs and implementation specifications. So we expect to see that proposed rule shortly. So lots of great work. The good news is that prior authorization seems to be a bounded problem. We know where the challenges are. We know the steps that we need to do to solve this issue. And so the next question is, how do we take the solutions that we're building for these components in prior auth and surrounding pieces and incorporate them into other processes? So one option is if we have a better data connection from when the patient shows up with an illness all the way through coding and reimbursement, then we can pull back that cost information up much sooner and provide shoppable services and price transparency, making it easier to schedule services and plan resources. So that's another work group in the Da Vinci project. Having such good information from the SNOMED side and NLP and on that unstructured text, plus more connections with CPT, gives more dimensions earlier in the process for clinical trial cohort matching. So we're keeping an eye on that. And then auto coding, we're hearing a lot of people, especially on the AMA side, in our developer program, who are looking at options for auto coding. So understanding how to apply these principles more broadly can solve a lot of different problems. So the next steps that we're tracking here and participating in, the first is just watching for these regulations to see what the impacts will be and then how payers and providers react. The AMA will be participating in the next couple of connectathons through HL7. There's a virtual one in January and a May in-person event where we'll demo these implementation guide use cases more fully. And then the big thing here around the implementation guides is that there is a lot of hesitation in the industry to adopt new processes that cost time and effort and money. And so when these implementation guides are refined, we heard Mickey Tripathi also reference some having the least burdensome effort to get these solutions out. If we have them in a format that is repeatable, then they can be more easily adopted by players in the health ecosystem. And so if you have any interest in participating in these work groups or adding to the conversation, those repeatable implementation guides and use cases are better with more perspectives. We'd love to hear from you directly or reach out to the HL7 groups to figure out how to participate more. So with that, I will take any questions and thank you for your time.
Thank you, Denis. We probably have time for just a couple of questions. If anybody in the room have a question, please approach the microphone.